Thank you. Assalamu alaikum. Thank you. Thanks for the opportunity to present. I recognize that this is a rare disease, but there have been some interesting updates recently, and we'll go through them as we go through this. So in a nutshell, this is a chronic lymphoproliferative disorder. There's about, in the United States, 600 to 800 new patients per year. But because of the indolence of the disease, the number of patients alive is much larger than that. And it's characterized by an accumulation of these characteristic cells that have these cytoplasmic extrusions, which are hair-like, and hence the name hairy cell leukemia. The key clinical features are splenomegaly and then sort of a bone marrow failure presentation with anemia, thrombocytopenia, neutropenia, and actually characteristic monocytopenia as well, often accompanied by bone marrow fibrosis and exquisite response to purine nucleoside analogs that we'll talk about. And then in the last several years, it's now recognized that nearly 100% of patients with the classic hairy cell leukemia have a mutation, the BRAF V600E mutation. So there's new consensus guidelines that we put together through the Hairy Cell Leukemia Foundation. Mike Griever is the first author, and I'll summarize a lot of that information to the talk. It's in press now at Blood. So the presenting signs and symptoms, as I mentioned before, is fatigue, frequent infections, splenomegaly, and or probably most commonly cytopenias on a blood counts, particularly monocytopenia, which is relatively somewhat specific for hairy cell. And then what really helps the diagnosis very clearly is the immunophenotype of the disease. So hairy cell leukemia in the classic hairy cell has a very specific immunophenotype, CD19/20 positive, but the cells also express CD11C and CD103, CD25 and CD123. This combination of markers defines classic hairy cell leukemia and differentiates it from several diseases which tend to mimic it, such as the hairy cell leukemia variant, which we'll talk about. Is also some very interesting new information about this rare disorder as well. And the big difference really between the two in terms of immunophenotype is a lack of CD25 and CD123 in the hairy cell leukemia variant. Trifine, bone marrow aspirate, and biopsy are very important in the diagnosis. The patients are frequently inaspirable at diagnosis due to the bone marrow fibrosis, but when you can do it, it's helpful, and the stains for CD20 and Annexin-1, and now in a monoclonal antibody to detect the BRAF V600 protein, VE1 antibody, is very specific and helpful as well in making the diagnosis. And so, as I mentioned earlier, there are several diseases which can mimic hairy cell, and it's very important to differentiate classic hairy cell from these mimic diseases, because unlike classic hairy cell, these disorders do not respond to purine nucleoside analogs. Interestingly, while the classic hairy cell has the BRAF V600E mutation, this disease, the hairy cell leukemia variant, which morphologically and clinically kind of mimics hairy cell, has mutations in the protein just downstream of BRAF, which is MEK1. And these patients will respond to BRAF inhibitors, whereas these would be totally resistant to them. And this would be important to make the differentiated two for that reason. So the majority of patients with hairy cell do require treatment at diagnosis. And indications for treatment are a lot like what we would require for CLL, anemia, thrombocytopenia, and or neutropenia. And in the absence of the above, if the patients have other clinical signs or symptoms of the disease, such as organomegaly, which is symptomatic, unexplained weight loss or fatigue, these may be kind of softer indications, just like we kind of do for CLL. Now, the first line of therapy is, and still is, a purine nucleoside analog, either cladribine or pentostatin, and these are extremely effective in their first line. So at least 60% up to maybe close to 100% of patients will achieve a CR with single-agent cladribine or pentostatin. However, with time, at least a third of patients will relapse, and as patients relapse, the likelihood of getting a remission decreases with time. Now, with that being said, there are several new treatment options for patients, the rare proportion that do become refractory or relapse following purine nucleoside analog, and I'll highlight those. So in the absence of renal impairment or active infection, the recommended treatment is cladribine or pentostatin. And there are several different ways to give cladribine, either by intravenous or sub-Q administration, and they can be given intravenously several different ways, or pentostatin, which is given IV every other week. Both of these medications are immunosuppressive and lymphosuppressive, so if there is active infection, we recommend either the infection or possibly use an agent not associated with myelosuppression, which in the past the main one was rituximab, but now, as I'll show you in a minute, vemurafenib is incredibly effective, the BRAF inhibitor in this disease, and is not associated with the same immunosuppression. And so there have been a couple cases recently where in the setting of an acute infection, this is actually the first treatment given. And I'll highlight the response to vemurafenib in a second. So we define response in hairy cell as follows: a normalization of the peripheral blood counts and regression of splenomegaly on physical exam, and the morphologic disappearance of hairy cells in the blood and bone marrow based on just light microscopy exam. It's very important to recognize the bone marrow should not be done too early after administration of treatment, because it doesn't normalize for at least 4 months after administration of cladribine or pentostatin. So recommend the bone marrow to be done at usually at least 6 months after initial treatment. Anything less than this is considered a partial response, and it's important to note that regardless of the response, further treatment is not warranted unless there's a hematologic or clinical reason to treat the patient further. So not achieving a CR is not a reason to continue treatment or advance treatment further. So most patients do have remission for more than 5 years. If the patient happens to relapse 5 years after initial therapy, the recommendation is to retreat with the same initial therapy. In a minority of patients, they will relapse less than 2 years after initial treatment. If that does happen, it's very important to confirm the diagnosis, because this is rare, although it does happen. We want to make sure here that the patient actually does indeed have classic hairy cell leukemia and not one of those mimicking disorders. And so it's important to confirm the diagnosis, particularly now very helpful through detection of the BRAF mutation, because this is nearly 100% of classic hairy cells will have this, and to look for one adverse prognosticator, which is the immunoglobulin heavy chain rearrangement, which is the IGHV4 through 34, which is present in a proportion of patients with classic hairy cell that are most aggressive. If the patient indeed does have classic hairy cell and relapsed less than 2 years after initial treatment, enrollment in a clinical trial, and as I'll highlight in a second with a RAF inhibitor, actually probably now hopefully off clinical trial, is actually strongly encouraged. In between these two, if the patient relapses between 2 and 5 years, you could consider just retreating again or adding rituximab to a purine nucleoside analog, and that's based on data showing increased efficacy if you combine rituximab with a purine nucleoside analog. So as I mentioned, Drs. Tiacci and Fellini discovered about 5 years ago now, nearly 100% of patients with hairy cell leukemia have this very curious mutation in the kinase BRAF, the V600E mutation. This is commonly seen in many epithelial cancers, but rarely seen in blood malignancies, except for in hairy cell leukemia, and now also we know in the disease histiocytosis, it's encountered commonly as well. And it's nearly 100% of classic hairy cell have this mutation. And so as a result of that, the patients, the hairy cells have ubiquitous expression of ERK kinase, which is downstream of BRAF, and this is a feature, again, fairly specific to hairy cell. And so what this entails is the following. So BRAF is a kinase downstream of RAS, the receptor tyrosine kinases that activate this RAF, MEK, ERK pathway. And in hairy cell leukemia, we know that this RAF is mutated and is constitutively activated, activating MEK and ERK as shown here. Interestingly, the hairy cell leukemia variant has a mutation downstream of this in MEK, which constitutively activates ERK. And this is all potentially important therapeutically because there are many RAF inhibitors that are very effective. There are also MEK inhibitors, and now there are even ERK inhibitors in early phase clinical trials. So that has led to the use of a question of, would RAF inhibitors be effective in this disease? And this is the first patient that was published with hairy cell to receive vemurafenib. And the case is very illustrative of many patients with hairy cell leukemia. So the patient was diagnosed in 2009 with the disease, was neutropenic at the time, received cladribine, which increased the white count, increased the neutrophils, but then over time it became neutropenic again, relapsed with the disease clinically, and was retreated with pentostatin, another nucleoside analog, then retreated again with pentostatin, then treated with cladribine and rituximab, and still was not in remission until they received vemurafenib in late 2011, and you can see very promptly restored their neutrophil count, white count, hemoglobin, and platelet count, and that was the only treatment actually that helped the patient over time. And so based on that, we initiated 2.5 years ago in the United States, centered at our center, a U.S. study of phase 2 clinical trial of vemurafenib in patients with relapsed refractory hairy cell. And a similar study was also started by Dr. Fellini in Italy at the same time, and we actually combined the two studies together, published late last year, the combined experience. And so this was patients for relapsed refractory hairy cell, single agent vemurafenib. Most of the patients were enrolled based on the fact that they had more than 2 relapses with a purine nucleoside analog. A few patients were intolerant to purine nucleoside analogs, and some just failed to achieve a remission with initial treatment. Most of them were relapsed more than twice, and all of them were requiring treatment because they were neutropenic at the time of study entry. Patients were treated for 3 months with vemurafenib, and if they did not achieve remission based on MRD by immunohistochemistry for hairy cells, they received 6 months total of vemurafenib, and then we stopped treatment. Most of the patients, this is the characteristics, so there was 28 patients from Italy and 26 from the US. Most were in their late 50s, early 60s. Most of them had been treated at least 3 times previously, and they were pretty advanced stage patients, with about a third of them already having splenectomy prior to entering the study. And so what we had seen is that vemurafenib was extremely effective. Patients restored their neutrophil count, hemoglobin, and platelets, usually within 1 month of receiving the drug. And as you can see here, this is flow cytometry showing you the proportion of hairy cells in the bloodstream and bone marrow of one patient. Within 24 hours, the hairy cells in the bloodstream and bone marrow were reduced drastically, and by 1 month, they're basically virtually eliminated from the body, and we see this in the vast majority of patients. So it's a nearly 100% response rate with vemurafenib in the relapsed refractory setting, with about half of the patients achieving a complete remission. And so in this late stage patients, there actually even were some deaths on the study because of how advanced the patients were. And this is the Kaplan-Meier curves for the US patients looking at overall survival and progression-free survival. This is looking by flow cytometry at a portion of hairy cells in the peripheral blood and bone marrow. So vemurafenib was very effective at reducing hairy cells and a little bit faster in the bloodstream clearance than the bone marrow, as shown here. And we also measured the BRAF mutation allele burden in the bloodstream in all the patients, and that also reduced over time with vemurafenib. There are some adverse effects, and this is very similar as seen in epithelial malignancies, which are related mostly to cutaneous toxicities of the drug, arthralgias, alopecia, and then photosensitivity and squamous cell carcinoma and other skin toxicities directly related to the on-target effects of vemurafenib. We started the treatment initially at 960 milligrams twice a day, and this is based on what's recommended for melanoma, and it's very clear now that that's actually too high of a dose, and the vast majority of patients ended up at around 480 milligrams daily with the treatment. Now, the last few points I'm going to make is there were some very interesting observations we saw. So patients were given treatment for only 3 or 6 months, and then it was discontinued. 7 patients following discontinuation of vemurafenib actually relapsed. And in these 7 patients, we restarted the drug. In the patients that we restarted the drug, they were able to achieve remission again, except for in one case. And I want to highlight that one case because it's actually very interesting. So this was a patient who was 77 years old, had relapsed hairy cell and massive splenomegaly at the time of enrollment. He had been treated previously with cladribine twice, with pentostatin, and with interferon, and at the time of the study entry had complex karyotype and deletion of 17p, which is all pretty unusual for hairy cell leukemia. Usually you have a normal karyotype. He started the drug on the study in July of 2013 and got 6 months of treatment, and had very good response with big improvement in splenomegaly and down to about 2 or 3% hairy cells in the bone marrow, and normalized his karyotype by the completion of 6 months of the drug. And so this is a graph showing the percentage of hairy cells in the blood on this axis and his white blood cell count. So he got 6 months of vemurafenib, and the white count decreased precipitously, percentage of hairy cells decreased greatly, and they normalized. And then we stopped the drug, which was part of the clinical trial. During the period of time that we stopped, his white count and hairy cells then returned in the bloodstream as shown here. So we restarted the drug, which is allowed on the clinical trial, and I should just point out his spleen. So this is his spleen at study enrollment. This is at the end of 6 months of vemurafenib, so it had shrunk. And at this point, his spleen had increased again. As we restarted vemurafenib, there was this very transient decrease in hairy cells and white blood cells, and then on therapy, the disease regrew again. And actually, during this time, he was quite ill and in the hospital. We performed a splenectomy, but unfortunately, he expired shortly thereafter. And what we found in this individual, and this is looking at the percentage of hairy cells in his bloodstream, so it was 94% at study enrollment, it went down to 2% and then relapsed, and then on the therapy, it still had, his disease was resistant to the drug. So what was going on? Well, in order to understand what the cause of the resistance was in this individual, we performed sequencing, and what we noticed very interestingly is that at the time of relapse of disease and when we restarted vemurafenib, he actually had acquired multiple KRAS mutant subclones within the BRAF mutant hairy cell leukemia, and this is a well-known resistance mechanism to vemurafenib and was the cause of his resistance, and actually presumably could have been avoided and or circumvented with the use of additional therapies, but we didn't know about this at the time during the study. And so this is probably the first example of a patient with a hematologic malignancy resistant to vemurafenib, and it's due to the acquisition of KRAS activating mutations. So to conclude, what we've seen from the clinical trial is that vemurafenib is very effective in the small proportion of patients with hairy cell leukemia that relapse from pentostatin or cladribine, and it can cause a 100% remission rate in those proportion of patients that are resistant to a purine nucleoside analog. We know that this pathway is a rational therapeutic target in hairy cell, and so it is being pursued further, and the side effects of vemurafenib are quite similar to that seen in other cancers such as melanoma. We still don't know the optimal dose and duration of vemurafenib in this disease. Should it be given for a limited period of time as we did in this study, or should it be given continuously as they do in solid tumors? And there are future clinical trials ongoing now combining a RAF inhibitor with MEK inhibitors because of this one resistant patient, and there are actually others that now have been seen and not reported in the literature yet, and or combining vemurafenib with anti-CD20 antibodies, again, only for the patients that are resistant to purine nucleoside analogs. So with that, I'll stop. I just want to acknowledge the collaborating institutions and our leukemia service at Sloan Kettering because this was a U.S. international study, and also our funding support and support from the Hairy Cell Leukemia Foundation for this work. So thanks very much.